One of the primary concerns for a lot of Americans is about their body weight. And we know that obesity has become a primary health concern globally, but also in the U.S. We see that our rate of obesity has gone up dramatically in every population. So young people, adults, and aging adults. And when we look at the trends, so in the year 2000, and this statistic is still pretty current, it might be within a few percentage points, about 64% of Americans are overweight or obese. Okay, so if we kind of look at it from the flip side, we're seeing that about 1/3 of Americans are at an appropriate body weight or maybe even slightly underweight. When we look at our obese population, this statistic here says 34%. I think the CDC's most recent figures are around 33 or 34%. So we have a tremendous number of people who are larger than they should be. And the result of this is that we see a lot of people dying before they should from obesity-related diseases. Now, I want to be kind of clear here that we don't die from obesity. It's all of the diseases that result from this obese condition. So when you think about the chronic diseases that are implicated in body weight, we can think about cardiovascular disease, we can think about stroke, there's some relationship also to cancer. You can even think about things that maybe don't kill us, but they really affect our quality of life, like osteoarthritis. You see people who are too large, having problems with their hips and with their knees and with their feet, poor circulation, increased risk of amputation, poor wound healing, immune function, fertility issues. So we have a lot of reasons to help people lose weight and also to maintain normal body weight. When we look at our obese population, 70% of those folks have at least one major health concern. And 50% of our hypertension or high blood pressure in the U.S. is due to body weight being higher than it should be. Now you can look at a map of the U.S., and you've probably seen these if you watch the news or are interested in health. We can look at a map of the U.S. and we can see that, we were pretty heavy in the 1990s, but we weren't where we are today. So this particular map is from 2002. If I were to update this, a decade later, we would see that most of the South here is actually a completely new color that isn't on our map, up to 30%, and in some states 35% of the population is obese. Now our healthiest state, if you maybe want to guess that, I'll give you a second to guess, it's Colorado. And one of the reasons there is that people get outside and they exercise and they're really active, and it's a healthy state. So, that's maybe a goal for us to work towards, some of the lifestyle practices they have there. Now, when we look at body weight, I've told you that there's a lot of consequences from being too large. There's also consequences from being too small, from being too thin. So we're going to talk about body mass index in a few minutes. But for right now, you've probably heard of this, and people say, my BMI is X, and this means that I'm underweight or normal weight or overweight or obese. If people have a very low BMI, that's considered to be a risk for health. If people are at a normal body weight, this is where we say that their risk is lowest. And then as we gain more weight and get really high BMI, so normally BMI starts 30, dictates obese, to 35, 40. Now I could keep going here. The CDC now has BMI charts that take us up into the 50s and 55 for BMI. And those are the folks that, again, we're very, very concerned about. As a general population, we've gotten larger, and the different classifications of obesity have expanded. So maybe back in the 70s, we just called folks obese, and now there are, I think, about 5 different classifications of obesity. There are risks to being overweight, as I said, and then there are also risks for being underweight. So folks who are in an underweight status are much more fragile if they are experiencing any kind of a disease, or even if they just get a common, mild illness. It's going to take longer for them to bounce back. And they're more susceptible to the common cold or the flu or something like that because their immune function is somewhat dampened. And if your book talks about this, and I thought it was an interesting point, that if people are hospitalized and they're a little bit underweight, it can be much, much harder for them to actually have the procedures done that they need to. You see this sometimes with people fighting cancer, that they've gone through a procedure and they've lost a tremendous amount of weight and they can't go on to the next treatment because they're just too thin. They won't survive it. They don't have the reserves. And if you know someone who is underweight, you might notice that their touch is very cold, that they have a hard time keeping warm. They might have a fine, like downy hair that grows on their body. It's just this way that your body naturally tries to keep you warm. They can have dampened fertility as well. So a woman who's underweight can find it very difficult to get pregnant. The woman may lose her period entirely, and more than 3 months, we call that amenorrhea, and that's a sign of something going on that we need to address medically very often. Now, let's take a look at some different indicators or different types of overweight. So we have a couple of classifications here, and I'll show you my models. We have a typical guy, and you can look at his fat pattern here. We call this an apple shape, and you've probably heard apples and pears before. There are a couple of different ways that we can talk about this clinically, besides just referring to this man as a fruit. You see that his adiposity is above his waist, and so we would call this central adiposity or visceral adiposity. So if you're not familiar with that term, viscera, it's really talking about your guts. It's in this region here. So he's storing and carrying his fat above his waist. So this is an apple. And then we have some women that take on this apple appearance, okay? And where she is carrying her weight above her waist. Most women, typically, their fat pattern is more of a pear. So it's below the waist. You can see here's her natural waist, and she's carrying her fat maybe in her belly, but also in her hips and her butt. We call this pear shape, if you want to get even more clinical, we call this a gynoid appearance, like the term gynecology, gynoid, and this is android. Okay, so we're more concerned with this android appearance. We see that when people carry that weight in this kind of upper abdominal region above their waist, it has certain health consequences. And it really increases our risk of diabetes, stroke, hypertension, and coronary artery disease. So we want to be very, very clear with people that it's not necessarily that you have extra fat mass on your body, it's where it's located. And I can even take a minute here and show you on another model how this looks if we were to see inside this person. So here you see this fat kind of around the body. This is subcutaneous, or it's kind of underneath the surface. This has a lot of really important functions. It keeps us warm, it provides a little bit of a cushion for us, it's protection, it stores vitamins, all those things. So we need to have body fat. What we don't need, on the other hand, is this kind of fat, so this visceral fat. And if you look here, it kind of looks like it's making its way, it's kind of infiltrating around these organs. And what you can't see here is that that fat is probably also inside some of these organs. So you can see fatty streaks in the liver and in the heart. Very, very dangerous. We don't want that. That's considered to be very destructive for health. There are different kinds of influences that will push people towards storing that fat in this central region. So it can be gender. We know that this is more likely the fat pattern that men will have. Menopause actually kind of promotes us, women go more towards this apple shape after menopause. Not every woman, but we see that that's a general pattern. Smoking and alcohol also affect fat deposition, and physical inactivity. So those are some of the ways that we can actually get traction towards this problem, because we can encourage people to be more active, to give up smoking, to use alcohol appropriately, and then take a look at their diet overall. When we talked a little bit earlier about some of the classifications with weight, we talked about this term BMI, body mass index. So I want to take a minute to kind of demystify this, and you'll be able to calculate this for yourself if you'd like to. So this is a function of weight and height. Okay, and you need to know both of those data points in order to calculate this. And if you look at my formula here, I have kilograms, and it's divided by height squared, okay, in meters. There are ways to figure this out in what we call the English system. Okay, this is metric. I strongly encourage you to use it as a metric equation, because healthcare runs on metric. It doesn't run on pounds and inches. Although doctors will measure people in that because it's what we're used to in the US, we use metric in healthcare. So when you calculate this, you'll need your weight. And if you know your weight in pounds, let's say you're 150 pounds, you simply divide that by 2.2, and it will give you your weight in kilograms. And if you know your height in inches and feet, all you have to do there is put it all into inches. So if you're, let's say you're 5 feet tall, for every foot you get 12 inches, so you'd be 60 inches. You're going to multiply that number of inches times 2.54, and that will give you your number of centimeters. Now we have to do one more thing here, because that's in centimeters. We need to move the decimal place twice, so that it would tell me how many meters tall I am. Okay, and then we have to square it. And again, if you haven't taken math for a while, squaring it is not multiplying it by 2, it's multiplying it by itself. Okay? And then you're going to simply divide. Now you can figure out this very, very easily with BMI calculators on websites. That's a simple way to do it. So plug those two numbers in and you'll come up with your BMI number. And you'll see then the next step is really for us to kind of interpret this number. So you can see our different classifications. So if your BMI worked out to be 21 or 22, somewhere in there, that would be considered a normal body weight. If it was less than that, let's say it was 17, then you would be considered underweight. And again, this is a range, right? So depending on where you fall within that might, be a little bit more of a concern. If you're right on the cusp, it might be a little bit of a concern, but if you're way down in BMI, it's a big, big concern for us. As well, when we start to look at BMI numbers outside of normal, after about 25, we see overweight and different classifications of obesity. BMI is a good tool in some respects because it's non-invasive. All I have to do is know somebody's height and weight. I don't even need to see the person necessarily to be able to figure this out. And it's non-invasive. I don't have to take your blood or anything really embarrassing. But there's some drawbacks as well. There are some populations where we wouldn't want to use BMI because it gives us really a false indicator of how their body is put together. So we don't want to use it with athletes. We know that muscle weighs more than fat. So if someone is very well muscled, their weight is going to be higher and it's going to then have a corresponding increase in their BMI. You don't use it with pregnant or lactating women because that's just unfair, right? It's actually two people here. And then also when women are lactating, they're taking on extra calories and they're using some of their stored body fat and things like that. So again, we don't use it with that population. Adults over 65 and then young children. And you will hear pediatricians talk about BMI. Maybe you take your child in for their annual exam and they figure out the BMI. Most likely, the pediatrician is using a specific age-related BMI chart for the child. So they're looking at other information there. That would be appropriate. However, if I were to measure my 12-year-old and then calculate BMI, that wouldn't be appropriate because I'm using a BMI formula that has been constructed for adults. It's not been constructed with children's needs in mind. So we have to be very, very cautious with how we use that. There's been a move recently for school systems to weigh and measure children and send home BMI letters. And a lot of parents will come to me and they're very, very concerned because they've gotten one of these letters and they don't know how to interpret it. So if you're in that situation, remember that BMI is one data point. It really tells us one thing about that child. And it really may not be a full story. It certainly isn't a full story in my mind. And it can be very, very concerning for parents. There are other ways for us actually to assess children. We call these, in a big classification term, anthropometrics. We can use these with adults, we can use these with children. So what we're doing here, we really want to look at body composition. Because the BMI measure just tells me what person weighs. I want to know how much fat they are, how much muscle, how much bone. Okay, so if we look at, I've got two people here. So we've got a typical man, young man it looks like, and he's 45% muscle. Okay, that's really tremendous. About half of his body is considered lean muscle. And then he's got 15% bone and about 15% body fat. That's very, very different than women. So she's smaller and she tends to have more body fat and less muscle. So again, BMI can be a little bit tricky with someone who's fairly well muscled and athletic. There are other things we can do to measure that body composition. So we can do a fat fold test. And let me tell you, people really don't like this very often. I've had it done numerous times. And what happens basically, they take a caliper, which is big like pinchers, and they pinch all these different regions in the body. So sometimes it's over the hip, sometimes it's subscapular. There are several data points. And they look, and you can do this for yourself at home. You can make a muscle in your arm and then pinch the area underneath where you would have skin. You can feel where the muscle stops. This is basically what the caliper is doing, and it's measuring that tissue underneath the muscle. You can also do underwater weighing. I don't know that this is used that much clinically. It's more of a research tool that I've seen it used. Basically, we're putting someone in the water in their swimsuit and putting them under, and we're looking at the water displacement, but also buoyancy to see how well they float. A person that tends to be more muscle has a harder time floating. We can use bioelectrical impedance, and these are very, very neat little devices. I have one, it's about $25 it costs, and what it does is it sends a very gentle electric current through the body, and they're measuring resistance here. So that current is going to move much more efficiently through aqueous tissue or muscle tissue, and it encounters more resistance in fat tissues. And so it will tell me the percentage of body fat and the percentage of muscle in my body, and it usually will calculate BMI in most models as well. That can be a really, really good tool for people, so much more than just a number on a scale. And one other comment about that is that when people are actively trying to lose weight and they're working out more, maybe doing some muscle building, it can be so frustrating for them because they actually see the scale go up. And what's happening is they're gaining muscle, and muscle weighs more than fat. So, keeping this in mind, we want to really, really push this idea of body composition. We can also use DEXA, and this is basically a full body scan and uses X-ray technology and measures the amount of muscle and fat and bone in every region of your body. I've had these done, and it's a great, great tool, especially for women, because it will tell you about your bone mineral density. And I think it's better to have that information now when you're young and can make changes to your diet and lifestyle than when you're older and your bones have already lost some mineral. We can also use waist circumference. And this is a very, very easy thing for people to do at home. And this is going to give us an indicator of where fat is deposited in our body. So we talked about how this adipose tissue above the waist, or the central adiposity, is a big concern. We have to be careful with how we measure our waist circumference. So if you think about women's fashions nowadays, low slung jeans, that's not where your waist is. You need to go through your belly button, okay? That's where we're going to have this landmark for measuring waist. In women, it should be no more than 35 inches. For men, 40 inches. And again, I'll see men, and sometimes what they'll do is they'll say, well, Lisa, I'm still wearing those 36 pants, but they've gotten lower and lower on their body, and they have this nice pendulous belly hanging over their normal waistline. Sorry guys, we're going to go right through that natural waistline, right through your belly button. So if you do this at home, keep these numbers in mind, 40 inches for guys and 35 for women. Okay, this is adults. And when we look at our increased risk for disease, this is a pretty good indicator because it tells us where fat is being deposited. Also the amount of just overall adiposity in the body. So we kind of looked at different ways we can measure body status, not only the amount that we weigh using BMI, but also we can look at where fat is located, and we can look at different ways of assessing body composition. The next thing we want to take a look at really is energy output and input and kind of where this balance is. This is very, very tricky. I will say that right off. Really figuring out someone's caloric needs is an art. There's complete science to it, but also there's a lot of art. We have a basal metabolic rate. So we'll just kind of start there in understanding this. And basal metabolic rate refers to all of these involuntary activities. I don't have to think about pumping blood around my body. I don't have to think about digesting my food, or all of these normal processes of just human existence. This is involuntary activity. So this is all the energy you need, this basal metabolic rate, to carry on those activities. Outside of that, we look at voluntary activities. So this is how much I move in the course of my day, how active I am, whether I walk to the grocery store, whether I get in the car and drive. That's where we actually can see a lot of energy expenditure depending on people's lifestyle. And then we have something called this thermic effective food. And this is really quite small. I would encourage you not to concentrate a whole lot on this, But this is in response to food in the system and eating meals and how metabolism changes around those activities. People will sometimes say to me, you know, every decade of my life, I feel like my metabolism has slowed and it's more difficult for me to lose weight, and I seem to be gaining a little bit of weight. And it can be a very, very small fluctuation. A difference of 40 calories every single day will result in about 1 pound of weight gain at the end of the year. And over a decade, that's 10 pounds. So it's no wonder that, you know, we tend to gain weight as we age. There are some things you can do to change your metabolism and to keep it really revved up and high. There's probably drugs you can do, but of course I don't want to go that direction. I really want to encourage people to be active. When you're physically active, you get that benefit of burning calories in that moment, but you also increase this overall metabolic rate so that you're burning calories at a higher rate than you normally would if you were a sedentary person. So it's kind of like a 2-for-1. You know, there's no downside to this. When we look at some food choices that people make, there are some words that we really need to spend some time defining properly, because I think Americans have forgotten what these things mean. So people will very often say, I'm so hungry. Well, what is hunger, right? It's very, very different compared to something called appetite. So when we look at hunger, this is a physical need for food. Okay, maybe you haven't eaten for several hours. Maybe you haven't even eaten since the night before. You go to bed, you get up in the morning, and you're hungry, right? This is true hunger because your stomach is empty and you're actually making hormones that encourage you to eat. The one that, and I've always loved this name, it's called ghrelin. It always reminds me of stomach growling, ghrelin. So ghrelin really triggers you to eat. Okay, this is an important hormone to make sure that your body has enough energy to carry out normal activities. There are factors that influence the production of ghrelin and these normal hunger cues. So nutrients in the bloodstream. Your body can assess the amount of triglycerides, the amount of sugar in your blood, and this can be an important indicator. Also the size and composition of the previous meal. So if I only have a saltine, you know, for breakfast or for lunch, of course I'm going to be hungry. That's not enough food. The weather, and you make different kinds of food choices depending on the weather. Exercise, that should make sense. If I'm burning a lot of calories, I need more. Sex hormones. So this is especially evident in young men. So if you have a teenage boy or you know a teenage boy and they have a lot of testosterone on board, they are eating machines, right? Because they're growing a lot of muscle, they're expanding their body, they're probably getting taller. So sex hormones play a big role. And then also illness. And of course, these can go both ways. Some people, when they're sick, they lose their sense of hunger and they're not going to eat. We could also add a couple other ones here to this list. You know, particular disease states I'm thinking of. People that are on some kinds of medications will increase hunger. Now keep in mind that hunger definition when we talk about something called appetite, because this is really moving in the other direction. So when we look at appetite, this is considered a psychological desire to eat, and you can experience appetite without hunger. So think about maybe you've gone to the movies recently, you just had dinner, you go to the movies and you smell popcorn, and you're like, oh yeah, I'm hungry. Well, you're not really hungry. You get this little clue or a cue to eat, and it's related to this sensory perception around food. So it's a mental drive to eat. Okay, so we have to be very, very careful of this because there are all kinds of cues around us that really provoke appetite. So it can be hormones, it can be your natural sense of appetite and hunger and food preferences. It can also be your customary eating habits. For instance, if I always eat breakfast at a certain time, I look at the clock, I'm like, okay, it's time for breakfast, but I really may not be hungry. It can be social interactions. So if you go to a party and everybody's eating and snacking, of course you're going to have this cue to do the same thing. Disease states, again, can increase appetite. Different kinds of drugs will do this as well. Mood-altering drugs in particular, but also medications that people might be on just naturally from their physician, street drugs, and then environmental conditions. So if you think about these different cues we have for appetite, I think it's very important for people to understand what their cues are. So when I've worked in diet counseling, I would often have women, if they were trying to reduce their body weight, talk about what encouraged them to eat. If they actually felt that their stomach was empty and they felt that stomach pang or kind of their stomach growling, versus they saw a commercial for Pizza Hut, or if they were grocery shopping and they saw something that looked really, really delicious. We need to really be very careful about satisfying appetite versus satisfying hunger, because we can get really in a lot of trouble if we're relying on appetite. We also want to be very, very clear about the state of our hunger. So we want to look at this word called satiety. And this is really just a feeling of fullness. Okay, so after a meal, if you think about maybe you just had dinner, and that feeling of fullness that you get, and it's kind of satisfaction. That's kind of the word we're talking about here. When we have foods that promote satiety, they tend to suppress hunger. So you probably already know what I'm going to say next. We want people to have high fiber meals. When you have fiber in the meal, it encourages or increases feelings of satiety, because that fiber stays in your system a little bit longer. It takes longer for your body to break it down. Also, water is important. And I've always thought this one was a little funny. Foods that are puffed up with air. So things that take a little bit longer to eat, maybe even something like popcorn. But again, we want to be really careful because cheese puffs also are puffed up with air, and that's not a good choice. So, use this one with a little bit of common sense. The other two, those make a lot of sense to us. So another way to think about this word satiety is satiation. And this is basically the same idea here. We actually see satiation being the result of these different kinds of receptors we have in our stomach. So when we have a meal that we've just eaten, the stomach stretches, and these receptors then produce a hormone and send that signal to our brain saying, you have enough food on board, you're completely full, you don't need to eat for a while. And this is really an important part of this whole hunger and appetite and satiety cascade. The hormone that's being produced when you actually have enough food on board is something called leptin. And I want to take a minute to kind of show you how this looks in animals. And this might be a little bit difficult to see here, but I've got two little mice. I think these are mice, not rats. We have a normal animal here that can produce leptin. And then if you look at this one over here, you see its little nose here. I don't even see its feet or its tail. It's basically a puffball of, mouse. This one does not make leptin. This little guy never gets the signal to stop eating. So as a result of that, he is constantly hungry, he is constantly eating, and you see what has happened to his waistline. It's expanded dramatically. This guy has the leptin, and he gets the signal, I'm full, I'm going to stop eating now. So hormones play a very, very important role in our perceptions of hunger and our perceptions of body satiety and kind of this satisfaction with our meals. So sometimes you'll hear this word leptin referred to people being leptin deficient, and as a result of that leptin deficiency, like our rodent over there, they're promoted to eat. This occurs very, very rarely. And if it is a situation where there's true leptin deficiency, it's often diagnosed very, very early in life, because it's a young child who can never be satisfied, is always absolutely ravenous. And as a result, they're very, very large. They're overeating. Okay? So there have been studies looking at, well, what happens if we give extra leptin to people? They already have normal leptin levels, but let's give them extra and see if that helps to control their appetite. It doesn't. It has not been effective. Leptin is a pretty complicated hormone, so there's still ongoing research, especially looking at the role that leptin plays in sexual maturation, especially with young girls, and signals about body composition. Let's look at some inside the body causes of obesity. We'll get to the outside ones in just a minute. We've talked about feelings of satiety and some of these other factors, but I want to give you a couple of statistics and kind of talk about why people might have an obese condition. There are lots of different factors that are involved in here, and we're really starting to just kind of get the tip of this. It's a very, very complex social problem as well as a physical problem. We know that if a child has at least one obese parent, there are genetic influences that increase their risk of obesity. So it's not just the environment the child grows up in, but it's also a genetic component. We do see overall with obesity that there are lifestyle choices. And there are people that can very easily override these feelings of satiety. I would say that every single person does that at some point. We eat past normal fullness. Maybe the food is particularly delicious, or maybe we're lonely, or we eat for all of these different reasons, and I think we really need to acknowledge that and sometimes take a step back from it. Again, when I was doing diet counseling, one of the things I would ask women to do is, when they were having a meal, to write down how they felt emotionally. A lot of women report being emotional eaters, and so we eat for all of these other reasons having nothing to do with hunger and this need to satisfy fuel needs. And boredom is a big one, loneliness, depression, so just being clued into those triggers. It can be very important. So let's look at some outside of the body causes of overeating. And these can be particularly difficult for us to overcome in a lot of ways because there are all of these different influences. We've talked about some of the different ones, loneliness and yearning, so kind of a sadness, different kinds of cravings that people might have for foods. We are programmed really to crave certain kinds of foods. And when you think about human existence and evolution, that's been very valuable. We've craved especially fat-rich foods, these dense, nutritious sources of food, because they didn't occur very often in the normal environment for humans. That served us well when we were, cave people, but it doesn't serve us very well now in this modern environment where there are so many sources of energy-rich, high-fat foods. It can be very, very difficult for humans to actually say, no, that's enough, I don't need that anymore, especially when we're getting a lot of cues from our environment around advertising. And think about the fact that there's really no place that we don't eat. I like to think we don't eat in the bathroom, but I think probably some people do. So consider that if you go to the supermarket, there's all kinds of ready-to-eat foods there, the bookstore, everywhere. Of course, addiction. A lot of people believe that food is a drug. I'll leave that up to you. It's a kind of a controversial stance. Compulsions, people get into compulsive cycles and habits around food. Depression, and even the time of day. People tend to snack a lot at night. And people will ask me if snacking at night causes weight gain. And it's not about the fact you're eating at night, it's really about the type of food that you're eating. So we have to have some caution around those snack foods and ice cream and chips and things like this. Food price and availability play into our choices, and especially advertising. And that is very, very true with young children who are highly impressionable. And especially when you consider that children today are watching more television than ever before. Physical inactivity. And this should be part of the equation as well. It's not just that we have diets that need improvement, but also we need to move more. And if you look at the histories of people who are obese, their energy intakes are not really all that different than people who are non-obese. It can be that they need to move more, and it can be very, very hard for someone who's larger to start an exercise routine. When you go to the gym, it's not set up for larger people. I completely acknowledge that, and it's not easy for people to make those changes in their life. So the next thing we're going to look at is actually weight reduction and some helpful strategies for weight loss.